Assessing a patient's social needs used to be considered a voluntary clinical best practice, but today it is a strict regulatory mandate, bringing severe audit consequences for practices that fail to comply. The shift started in January 2024, when the Centers for Medicare and Medicaid Services required mandatory inpatient reporting for social determinants of health. Now, CMS is moving to expand those mandatory screenings to outpatient settings by 2026. To be compliant, practices must screen patients across 5 specific domains: food insecurity, housing instability, interpersonal safety, transportation challenges, and utility difficulties. The Joint Commission updated its accreditation standards alongside CMS. They tied specific elements of performance directly to whether practices conduct these screenings and how thoroughly they record the data. The policy infrastructure now mirrors the clinical evidence. Mid-size practices face immediate audit exposure if they fail to build dedicated systems to track and document these required metrics. On the clinic floor, this new administrative burden falls on an already depleted front office staff who are trying to manage scheduling, intake, and insurance verification at the same time. This chart illustrates the primary challenges cited by medical group leaders in a recent MGMA poll. Finding qualified candidates heavily outweighs compensation and retention issues, with 53% of leaders calling it their single biggest hurdle. When that struggle is tracked on this line graph, the financial and operational damage becomes clear. Front office support staff have a 40% turnover rate, and replacing just one frontline employee costs a practice between $25,000 and $30,000. High turnover systematically destroys institutional knowledge. As trained staff vanish from the workflow, screenings get skipped, creating dangerous documentation gaps that immediately trigger compliance failures. This is the core collision. Practices are legally required to execute complex, sensitive social assessments while simultaneously lacking the basic manpower needed to do the work. A compliant social connection workflow requires 4 exact steps: screen the patient, identify the need, coordinate the community resource, and document the outcome. In a chaotic clinical environment, the first failure point is the documentation gap. Staff often write notes in free text, but CMS reporting requires the use of structured data fields and specific checkboxes. Without a dedicated coordinator, those boxes are easily missed. The second failure point is the referral gap. Handing a patient a printout for a housing program is very different from verifying the community resource actually connected with the patient. When referrals fall through the cracks, unmet social needs result in sicker patients. They return with more complex conditions, which drives up readmissions and suppresses practice quality scores. Treating social connection as a secondary add-on task for front desk staff guarantees workflow failure. The process requires dedicated attention to succeed. To solve this, practices are partnering with healthcare outsourcing firms. These companies provide highly trained virtual medical assistants, or VMAs, dedicated exclusively to the social connection workflow. These VMAs do not use external spreadsheets. They operate natively within the practice's existing electronic health record system to administer standardized screenings in real time. Integrated AI patches the documentation gap. Natural language processing scans intake documents and sorts extracted data into structured database fields for CMS audits. To secure this, a management structure locks in. A team leader, process manager, and customer success manager provide 3 oversight layers. Outsourcing to a dedicated AI-assisted team entirely removes the burden of hiring, training, and managing from the local practice while delivering consistent, audit-ready documentation. Relying on local staff to meet these compliance mandates creates a severe, hidden financial liability. We can quantify that liability in this split-screen comparison. Maintaining an in-house social connection coordinator carries a fully loaded annual cost of $60,800. Staffingly provides a dedicated VMA for a fixed annual cost of $21,600. That is a 64% cost reduction. The $39,200 difference drops directly back to the practice as pure retained revenue per full-time equivalent. If a mid-size practice replaces 3 in-house administrative positions, they return over $117,000 to their bottom line every year. This is an economic realignment. The data shows how this model moves the financial burden from a fluctuating payroll liability to a completely fixed, predictable operational cost. The operational transition is fast. A Staffingly team connects to the practice's EHR and goes live in just 48 to 72 hours. The foundational data security architecture is strict, maintaining active HIPAA, SOC 2 Type 2, ISO 27001, and HITRS certifications. There is zero financial risk to evaluate the system. The service requires no long-term vendor contracts and begins with a 30-day free trial. The 2026 mandates require a coordination strategy that doesn't rely on an already overextended clinical team. Claim your trial today by visiting staffingly.com/demo or calling 800-489-5877.